Good afternoon all. On behalf of Unit 1, Department of Surgical Disciplines, I welcome you all to our CGR, Panorama of MEN Syndromes. So before I get into the trouble of gender bias, I'll quickly move on to what exactly MEN is. So it is essentially a syndrome wherein at least two endocrine organs should be affected. And apart from that, there may be non-endocrine association also. And these are inherited disorders and divided into 5 major groups, MEN 1 to MEN 5. So in MEN 1, which is the commonest one, we have in endocrine diseases, we have pituitary, parathyroid and pancreas. And apart from that, we can have carcinoids in various locations, adrenal cortical tumors, non-medullary thyroid neoplasms and pheochromocytomas. And in non-endocrine lipomas, angiomas and collagenomas. So these are the various associations. And interestingly, the death here occurs because of carcinoids or pancreatic endocrine carcinomas, PENEC. MEN 2 syndrome comprises of two categories, MEN 2A and 2B. 2B is nowadays MEN 3, so making it 1, 2, 3. So in MEN 2A, thyroid, parathyroid and adrenals are affected, and MEN 3, that is MEN 2B, thyroid and adrenal, thyroid medullary carcinoma thyroid occurs. So all these are inherited disorders, MEN 1 in chromosome 11 and MEN 2 chromosome 10. Why low index of suspicion should be there? Because some of them are fatal conditions and some carry poor prognosis. So whenever any of these conditions are encountered, we should try hard to establish a syndromic association. And the last two, MEN 4 and MEN 5, rare, but we have pituitary, parathyroid and pancreas in affected. In MEN 5, again the same. Here the genetic mutation is MAX gene. Apart from that, we have ganglionoma, RCC, as other associations. So primarily we have commonest MEN 1, then followed by MEN 2A, 2B, 2B is MEN 3 now. So we'll be discussing these three in detail. And as the diagnosis, early diagnosis is very, very important. We should know how to evaluate and clinch the diagnosis. For that, I'll call Dr. Rakesh from Department of Endocrinology to take you further. Thank you.
Good afternoon all. As already discussed regarding various components related to MEN syndrome. So briefly summarizing, MEN 1 majorly consists of parathyroid adenoma, enteropancreatic tumors and pituitary adenoma and various other associated tumors. MEN 2 majorly involves medullary thyroid carcinoma, pheochromocytoma and parathyroid adenoma. And MEN 2B, which is also known as MEN 3, involves medullary thyroid carcinoma, pheochromocytoma and various clinical phenotypes associated with MEN 3. So when to suspect MEN 1? 2 or more MEN 1 associated endocrine tumors, first degree relatives of MEN 1 mutation carrier with MEN 1 associated tumors, patient with features suspicious of MEN 1 with parathyroid adenoma occurring at the age of below 30 years, presence of multiple parathyroid adenoma, gastrinoma or pancreatic neuroendocrine tumor at any age, or 2 or more MEN 1 associated tumor that are not part of classical type. So earliest age of manifestation has been seen at 4 years and latest age has been seen till 83 years. So for screening involves screening of high risk individuals that have high risk of developing MEN 1 related tumors for screening of index cases. So basically we involve screening involves clinical evaluation, biochemical workup and radiological workup. So clinical evaluation is based on sign and symptom of various MEN 1 related tumors. Biochemical evaluation involves targeted screening for various MEN 1 related tumors, and radiological workup is suggested if the clinical and biochemical investigation are suggestive of specific tumors. So coming to the data from AIIMS, among 43 MEN 1 associated patients, 90% of the patients have a primary hyperparathyroidism, 79% of patients has gastrointestinal pancreatic neuroendocrine tumor, and 37% of the patient has pituitary adenoma. And the most common phenotype seen was the combined co-occurrence of primary hyperthyroidism with gastrointestinal pancreatic neuroendocrine tumor that was seen in around 42% of the patients of MEN 1. So coming to the comparison of sporadic primary hyperparathyroidism with the PHPT seen in the MEN 1 patients, the MEN 1 PHPT patients had a significantly younger age at onset, lower mean serum calcium and alkaline phosphatase, lower BMD at lumbar spine and femoral length, and high rate of nephrolithiasis. So coming to the biochemical workup in the MEN1 tumor, for parathyroid, we do serum calcium, phosphate, albumin with alkaline measurement of alkaline phosphatase and intact PTH. For pancreatic and duodenal neuroendocrine tumor, we, as per for screening of gastrinoma, we do serum gastrin level, or if required, provocation testing. For insulinoma, we do the assessment during the hypoglycemia with critical blood glucose level of less than 54 milligram per deciliter and document hyperinsulinic hypoglycemia. For non-functioning, we do various imaging workup. For pituitary adenoma, if we are suspecting somatotropinoma, then IGF-1 based screening is done. For prolactinoma, prolactin measurement will be done. And if high suspicion is there in the presence of normal prolactin, then prolactin assessment in dilution can be done. For Cushing syndrome, cortisol and further workup suspected of Cushing syndrome can be done. For adrenal tumor, the screening of functional and non-functional adrenal tumors has to be done based on the measurement of the cortisol or DST levels, 24-hour urinary catecholamines, and plasma fractionated metanephrine. And for the screening of primary aldosteronism based on the assessment of aldosterone and direct training concentration. Similarly, for the assessment of bronchial and thymic carcinoma, cortisol and ACTH screening has to be done. So the screening guidelines for age-based screening guidelines for the patient with the MEN1 related tumors. For screening for prolactinoma and somatotropinoma with the prolactin and IGF-1 starts at the age of 5 years. For insulinoma, it starts at the age of 5 years. For parathyroid, screening has to be done starting from the age of 8 years. For other pancreatic neuroendocrine tumor, pituitary adenoma and adrenocortical adenoma, it has to be done starting from the age of 10 years. For thymic and bronchial carcinoma, it should be started at the age of 15 years, and for gastrinoma, it should be started at the age of 20 years. Coming to the MEN2 basically arises from the mutation that mutation that mostly frequently occur in the cysteine-rich domain in the extracellular domain and intracellular tyrosine kinase domain. It is there is a strong genotype and phenotype correlation in the MEN2 syndrome, and the mutations are further categorized based on the risk of medullary thyroid cancer into highest, high, and moderates. Various variants in the MEN2 syndrome are familial NPC, MEN2 with cutaneous lichen amyloidosis, and Hirschsprung disease. In MEN2B, which is also known as MEN3B syndrome, various clinical phenotypes seen apart from the medullary thyroid and pheochromocytoma are Murphy-node habitus, S. cavus, high arch palate, mucosal neuroma, dilated megacolon, and medulated corneal nerve fibers. As per the data from the AIIMS, as per the study done by the Passer et al. In 64 patients from 25 families, the medullary thyroid carcinoma was seen in the 100% of the index patient, and 77% of the index patient had pheochromocytoma. However, in the families of MEN2 patient, 93% of the patient had medullary thyroid carcinoma. Comparison to pheochromocytoma was seen in 50% of patients. However, in MEN2B patients, which were 5 in number, and 100% patient had medullary thyroid carcinoma, compared to pheochromocytoma was seen in 4 out of 5 patients. So the highest risk of medullary thyroid carcinoma was seen in mutation at the exon 16 at codon 918, with 50% having the penetrance of pheochromocytoma. And the high risk mutation was codon 634 at exon 11, where the penetrance of pheochromocytoma was seen in 50% of patients, and penetrance of primary hyperparathyroidism is seen in 20 to 30% of patients. So whenever medullary thyroid carcinoma is suspected, basal calcitonin has to be done, which is reference age is assay specific, age and sex related, and higher in males and children less than 3 years of age. Also, high value can be seen in the presence of heterophilia antibodies and other causes of elevated calcitonin, which can be seen in the patients with chronic renal failure, parathyroid disease, thyroiditis, and other neuroendocrine tumor. Falsely low value can be seen in hook effect or during tumor dedifferentiation whenever there is a high suspicion of medullary thyroid carcinoma in the presence of low calcitonin, then CEA has also to be done if the metastasis has been suspected and there is a suspicion of tumor dedifferentiation. Provocation testing can also be done with the help of calcium and pentacalcine. So pheochromocytoma in MEN2 and MEN3, they are synchronous with medullary thyroid carcinoma in around 35% of the cases, bilateral in up to 50% of cases. More than 95% of the cases are benign, more than 95% arise within the adrenal gland. They are typically associated with adrenergic symptoms and should always be worked up prior to surgery for medullary thyroid carcinoma. So for biochemical workup for medullary thyroid carcinoma, serum calcitonin, CEA, and cortisol and ACTH is done if ectopic Cushing syndrome is suspected. For adrenal tumor, 24-hour urinary catecholamine and plasma fractionated metanephrine has to be done. For parathyroid disorders, screening for primary hyperparathyroidism has to be done. So coming to the recommendation, as per the based on the genotype, the highest risk ADC are the one which have the mutation at the exon 16 with codon 918, and the measurement of calcitonin and screening for the PHP medullary thyroid carcinoma has to be started as soon as possible, and prophylactic thyroidectomy has to be recommended as soon as possible or prior to 1 year of age, and screening for pheochromocytoma has to be started by the age of 11 years. For high-risk mutation, the prophylactic thyroidectomy has been recommended by the age of 5 years, and screening of pheochromocytoma and PHPT has to be started by the age of 11 years. For moderate risk category mutation, the prophylactic thyroidectomy has been recommended by the age of 5 years, and screening of PCC and hereditary hyperparathyroidism has to be started by the age of 16. So I invite Dr. Srija for analytical imaging.
Good afternoon. So now we will see some of these lesions, how they appear radiologically. So firstly, for 4D-CT. So 4D-CT is done to look for parathyroid adenoma. So in 4D-CT, what we do is we take a non-contrast imaging, then one arterial phase imaging, and then one venous phase imaging. So this is the non-contrast axial and coronal scans. We can see that a 4 to 5 mm lesion is seen at the posterior aspect of the right lobe of thyroid, which on arterial phase imaging we can see it is appearing hyperenhancing, as well as we can also appreciate this thyroid gland, which is showing some lesions. It was actually a medullary thyroid carcinoma. So on venous phase we can see the same lesions which is showing subtle washout. So now comparing the non-contrast arterial phase and the venous phase imaging, we can see in the posterior inferior aspect of the thyroid, right thyroid lobe, with this structures which is hyperenhancing compared to the thyroid gland in the arterial phase imaging, and showing some washout in the venous phase imaging. Here both thyroid and parathyroid appears almost similar. So this was a case of parathyroid adenoma. Then CMRI is done. In CMRI, brain is done in case of pituitary macro or microadenoma. For microadenoma, dynamic contrast enhanced is advised. So in axial flare images, we can see the hyper intense lesion in the cella, in the bulky pituitary gland on the right aspect. On demarcated images, we cannot appreciate any lesion per se, but we can definitely appreciate that on the right side of the gland it appears bulky and the stalk is deviated towards the left. So there is a lesion on the right side of the pituitary gland. On T2 images, we can appreciate hyperintense lesion on the right side of the gland with the hyperintense rim, which on dynamic contrast images is not showing any contrast enhancement compared to the rest of the pituitary gland, because adenoma shows delayed enhancement. So this was a pituitary macroadenoma with cystic degeneration. So for adrenal, to look for pheochromocytoma, CCT adrenal protocol is done. What we do in our adrenal protocol is we take one non-contrast images, then a venous phase images at 60 to 70%, and then a delayed phase images on 15 minutes. So I'm going to calculate the HU value at these sections. Here we can appreciate a well-defined oval lesion at the suprarenal region, which is not infiltrating the adjacent structures, which has an HU value of 27, and on venous phase images it has a HU value of 105, and on delayed phase we have an HU value of 64. And on the column we can see appreciate this suprarenal lesion. So by this formula we can calculate the absolute washout. So the absolute washout in our case was 53%. If the washout was more than 60%, then a diagnosis of adenoma to be made. But in this case, in syndromic patients, washout being less than 60%, so it was diagnosed. So we can say it's a case of either pheochromocytoma or malignancy. So next, I'd like to invite Yogita Khandelwal for functional imaging.
Good afternoon, everyone. Today I'll be presenting the role of nuclear medicine in MEN syndrome. So we have role in imaging as well as therapy. So these are the variety of lesions seen in the MEN syndrome. So for parathyroid hyperplasia, we imaged by 99M technetium system UV scintigraphy or 18F fluorocholine PET CT. Then in pancreatic tumors or other neuroendocrine tumors, for well differentiated, we use 68 gallium Dutatoc PET CT. And for poorly differentiated or for prognostication, we use 18F FDG PET CT. For medullary thyroid carcinoma, if serum calcitonin is elevated, we image the patient by 68 gallium butanol PET CT, and if there is elevated CA, 18F FDG PET CT is done. For evaluation of pheochromocytoma, we have iodine 131 MIBG scintigraphy, or alternatively 68 gallium butanol PET CT or 18F DOPA PET CT. So I would like a brief introduction of 68 gallium butanol PET CT, where it is showing normal physiological distribution. It is seen in pituitary, salivary glands, mild uptake in the thyroid glands, liver and spleen, adrenal medulla, kidneys and bladder, and mild uptake in bowel. So in a patient of MEN1 syndrome, we do 99M technetium system AB scan to look for parathyroid adenoma or hyperplasia. So these are the planar images, early and delayed, which is showing normal physiological distribution in salivary glands and the thyroid gland, which shows washed out in the delayed images, where we can see faint tracer uptake inferior to the right lobe of thyroid and a focal tracer uptake inferior to the left lobe of the thyroid. In SPECT CT, soft tissue lesion is seen inferior to both lobes of thyroid, consistent with bilateral inferior parathyroid adenomas. So the same patient underwent 68 gallium butanol PET CT, and we can see the SSTR expressing soft tissue lesions in the axial as well as coronal images, consistent with bilateral inferior parathyroid adenomas. Additionally, there was a focal tracer uptake with ill-defined soft tissue lesions on the tail of the pancreas, suspected to be neuroendocrine tumor of the pancreas. In MEN2A syndrome, we are looking for medullary thyroid carcinoma and bilateral pheochromocytoma in this patient. So, on imaging, there was a soft tissue lesion with calcification and necrosis and variable SSTR expression. Additionally, there was well-defined lesion showing intense uptake in bilateral suprarenal region. Thus, patient was with medullary thyroid carcinoma and bilateral pheochromocytoma. In MEN2B syndrome, again we are suspecting medullary thyroid carcinoma and pheochromocytoma. So in this, we can see a well-defined lesion involving left lobe of the thyroid with bilateral upper paratracheal lymph nodes, and there was non-tracer evidence, subcentimetric small nodules in bilateral lung fields. Thus, this patient was metastatic medullary thyroid carcinoma, and there was a well-defined soft tissue lesion in suprarenal region, in bilateral suprarenal region, consistent with bilateral pheochromocytoma. Thus, we can help in the staging of these patients. So this is again a patient of MEN1 syndrome. Here, the 99M technetium system EB scan was done, which shows normal physiological uptake in the salivary gland in early and delayed images. The washout was mild in the planar images. Thus, the SPECT CT was helpful in diagnosing the parathyroid adenoma. As we can see, there's a soft tissue lesion posterior to the left lobe of thyroid, suggestive of left superior parathyroid adenoma. This patient underwent 68 gallium butanol PET CT, in which we can see a soft tissue lesion in cellar and supracellular region, consistent with pituitary adenoma. The lesion which was seen in scintigraphy is also seen in 68 gallium butanol PET CT. Additionally, there were ill-defined SSTR expressing soft tissue lesion in the uncinate and head of pancreas, consistent with neuroendocrine tumor of the pancreas. So this patient underwent surgery for pituitary and parathyroid adenomas and was on injection octreotide for the neuroendocrine tumors. So the patient was followed up after 2 years for 68 gallium butanol PET CT, in which the lesions in the pituitary and parathyroid were not visualized. However, it showed stable disease of the pancreatic tumors. Thus, the role of PET CT is also in the treatment response and follow-up. So, a brief summary about the therapy. In neuroendocrine tumors, we give 177 lutetium PRRT therapy, and for pheochromocytoma, we give iodine 131 MIBG or 177 lutetium PRRT therapy in metastatic, inoperable, functional, progressive, or recurrent disease patient. So, this is a MEN2B syndrome patient, metastatic medullary thyroid carcinoma. When the patient was referred to us, the serum calcitonin was of 16,000 and serum CA of 250. The patient underwent 6 cycles of 177 lutetium glutatate therapy. The therapy is given in the interval of 2 months. Thus, after 1 year, there was a decrease in serum calcitonin and serum CA. On the axial imaging, the lower cervical lymph node, subcarinal lymph nodes, and liver lesions showed stable disease. So take-home message from nuclear medicine is the nuclear medicine has role in imaging and therapy, thus helping in diagnosis, staging, localization of the lesions for parathyroid, restaging or recurrence, treatment response, and prognostication. Now I would like to call Dr. Nitin Chaudhary from anesthesia.
Thank you, Dr. Yogita. So, going ahead with the perioperative management, these patients can come up with for various surgeries to anesthesia, but I think the ticking time bomb is pheochromocytoma. So, let's just try and diffuse this time bomb before the patient actually loses. So, when a patient of pheochromocytoma comes to us, what are the goals for any anesthetist who's going to be a part of the team? The first is the pharmacological optimization, as these patients can swing both ways, preoperatively as a hypertensive crisis and in the post-op as a hypertensive. Then the syndromic associations, these patients may have various syndromic associations we've already talked about depending upon the MEN syndrome to which they belong. They may require medications for coexisting illnesses. Other than the MEN syndrome, they may also have certain comorbidities such as CAD, hypertension. So these diseases may get compounded when you have an underlying pheochromocytoma in a patient. You require stable intraoperative hemodynamics, avoiding the perioperative cardiac events, and preventing and treating the vasoplasia that would happen once the tumor is out of the body. So why you need to optimize these patients? As an anesthetist, I'm sure everyone talks about pre-anesthetic checkup, and why these pre-anesthetic checkups are required is because we want to optimize these patients in the pre-operative period, especially a patient of pheochromocytoma. The rationale is very simple. If you look at the census or the data that's been there, about 25 to 50% of the patients were lost just at the time of induction before the concept of optimization came into existence. And from the time this optimization was brought into picture, this figure has drastically reduced from 25 to 50% to mere 3%. So you can see the drastic reduction in the morbidity and the mortality of the patient. Other than these patients, as we know, are at a very high risk of hypertensive crisis before or during the surgery, and followed by surgery, they may go into hypertensive crisis. So optimization helps us to overcome these problems that a patient might suffer during the perioperative period. So when do you know that the patient is actually optimized, when the patient can really go in for a surgery? So we have this Rosen's criteria which has been established, wherein if the supine arterial blood pressure of the patient is less than 160 systolic and 90 diastolic, that's one of the criteria to establish that the patient has been optimized. Other than that, we have the orthostatic hypertension, which should not be there. If the patient has an orthostatic hypertension wherein the BP falls less than 85 systolic and 45 diastolic, that means the patient is yet to be further optimized. Any ECG changes, ECG should be free of any ST or T wave changes for at least the last 2 weeks, and there should not be any premature ventricular contractions of more than 5 per minute. So once you have all these 4 criteria fulfilled, you know that the patient has been optimized and is ready to go for the surgery. So coming to induction, now the main soul of induction is that you would try to avoid the release of catecholamines. So any drug, anything that's going to make the adrenals secrete catecholamines, you are trying to avoid them. So pre-medication, yes, because anxiety per se would help the patient if you have an anxiolytic drug available, it will help the patient to have stable hemodynamics. Hypnotic agents should be more hemodynamically stable. So you're not going to use something like ketamine or any drug that's going to surge the blood pressure of the patient. So propofol or etomidate is a very good option available. Coming to opiates, we avoid morphine because of the histamine release, and even in muscle relaxant, you avoid etracurium because of the histamine release. Succinylcholine is avoided because it itself can cause, the fasciculations that you see with catecholamines can compress all the tumors, resulting in release of large degree of catecholamines. So once you have induced this patient, what about the monitoring? Should we go by the standard monitoring, or these patients are at high risk, so we need to be more vigilant? So other than the routine ASA grading, ASA monitoring that is given to all the patients, these patients definitely require large bore access because of the hypertensive crisis or the hypertension, so-called the vasoplasia that might set in once the tumor is out of the body. So you require an arterial cannula so that you have a beat-to-beat variability and you can titrate your inotropes, your vasopressors, and your antihypertensive drugs to tide over these crises. So what are the 2 phases that we are really worried about? One is before the vein has been clamped. At that point of time, any stimulus in the form of endotracheal intubation, positioning, skin incision, a peritoneal insufflation in case you're going for a laparoscopic surgery, or a tumor manipulation before it's been ligated will cause a surge in the catecholamines because of the various reasons as mentioned here. So what when there is a hypertensive crisis? So the first thing that an anesthetist need to do is you need to ensure that the patient is in a good plane of anesthesia or a deeper plane of anesthesia. Once that is ensured, you would be titrating your antihypertensive agents. Now, these antihypertensive agents have to be quick. They have to act quickly. So you would use something that acts rapidly and has a short duration of action. Because once the tumor is out, the hypertension will set in. And if you use drugs which are long acting, then you would have to combat your antihypertensives along with the vasopressia that are set in. So the commonly used drugs that we in our setup is the sodium nitroprusside and nitroglycerin. And in case you have a persistent hypertension, magnesium sulfate is a newer drug that can be used. Next phase is the phase of vasopressia. That is when the vein has been clamped. That is when you find a precipitous hypertension because of decrease in the circulating endocrine catecholamine levels, or the down regulation of the alpha adrenoceptors that has happened, or because of the prevailing action of the alpha blockers that the patient was already taking. So in these cases, the first thing is a communication. You should have a good communication with your surgeon. If the surgeon is about to clamp the vessel, he should be telling or she should be telling you that I'm going to do this step, so that you're sure of two things. Firstly, that your inotropes and your vasopressors are well in line, so that you can use them. And secondly, you have hydrated and you have resuscitated your patient well in time before the vasopressia sets in. So once that is done, still you have hypertension, you can treat it. If you feel that the volume depletion is the cause, you can go for a fluid resuscitation followed by your vasopressor or inotropes. Lastly, the post-operative management. So these patients may still exhibit hypertensive, hemodynamic instability can be there because of the vasopressia. So in case the patient is on a higher dose of inotropes or a vasopressor, it is preferable that you do not extubate this patient, and these patients are brought into the intensive care unit till the time the blood pressure is under control. In case you have a persistent hypertension, you need to, other than the vasopressia, there are other causes of hypertension which should be kept in mind. Could be a surgical bleed, could be an inadequate resuscitation from the anesthetic end, or a residual vasodilatation because of the various anesthetic drugs that you have been using. Other than this, the patient can also present with persistent hypertension. Now, this can be because of the fluid overload or the return of the autonomic reflexes and inadvertent ligation of the renal artery and a presence of a residual tumor. So you need to really discuss with your team as to what can be the possible cause in case the usual things do not act well in your patient. So in case hypertension, you see the hypertension in the postoperative period, you need not be worried, because 50% of the patient do precipitate hypertension even 1 to 3 days after the tumor has been excised, and up to 75% of the patient become normotensive after up to 10 days. So you need not find a sudden decrease in the blood pressure in the postoperative period. If you still have hypertensive crisis, wait for some time before you make a judgment that maybe the tumor is not entirely excised. Other than this, you have to be watchful about the electrolyte disturbances, the endocrine abnormalities that the patient might have. The blood glucose monitoring should be done. And lastly, a careful attention should be paid to the fluid management. Thank you so much.
Thank you, sir. For surgical management of MEN syndrome, so the issue with these patients is that they have multiple tumors in same organs, or they have involvement of multiple organs. So the question comes to our mind that which to operate first. So in cases of MEN syndrome, where there is primary hyperparathyroidism with pancreatic neuroendocrine tumor, if it is insulinoma, that should be operated first. Otherwise, PHPT is operated first. And in cases of MEN2, pheochromocytoma should always be operated before going to surgery for medullary thyroid carcinoma. Although this is traditional teaching, now with improved perioperative care, all these tumors can be dealt with in same setting. So coming to the individual organs, the conventional approach for hyperparathyroidism in these patients is total parathyroidectomy with autotransplantation of part of the smallest gland in the left forearm. And other than that, now the unilateral exploration and focused parathyroidectomy are also feasible options. So as we can see that the parathyroid glands lie way back in the neck at the level of esophagus, behind all these organs, including strap muscles and thyroid, and during surgery we have to reach there. So this is an operative video of a MEN1 patient with a single enlarged gland. So we had done a focused parathyroidectomy in this case. So we can see that after raising subplatysmal flap and after splitting the strap muscles, we identify the thyroid, and then after medial rotation of the thyroid, we can identify parathyroid gland, which is meticulously being dissected, and after ligation of the vascular pedicle, it can be excised. So these are some of the specimen pictures of total parathyroidectomy patients. So in this, we can see that there is an enlarged left superior parathyroid gland, but the rest of the glands appear normal in size, where in this case, all these parathyroid glands are enlarged in size. So in both these cases, the smallest part of the smallest gland was auto-transplanted into left forearm of these patients. For treatment of pheochromocytoma, as sir has already described, adequate preoperative preparation is a must. After that, any of these approaches can be taken for adrenalectomy. So this is how we position the patient for right adrenalectomy, and these are the surgical steps in anatomy for left adrenalectomy. So we see that there is colon, there is spleen, and here somewhere is kidney. So both of these structures are mobilized medially, following which an dissection is done in the Girota's fascia at the upper pole of the kidney, and we can identify the adrenal gland there, and then we can identify adrenal vein draining into the left renal vein, which can be clipped. So this is the surgical video of the same procedure. So we see that the colon here is being mobilized, following which the spleen is being mobilized here. And then dissecting at the upper pole of the kidney, we can identify adrenal gland. So this is the adrenal gland which is being dissected. After clipping the vascular pedicle, it can be excised. This is another video of a robotic right adrenalectomy. So this is how we place the port, and after retracting the liver, we can identify the adrenal mass here. So the medial dissection is being performed here, and after completing medial dissection, we have to dissect the adrenal gland from the IVC, which is seen here, and we can eventually identify the adrenal vein draining directly into the IVC, which is being clipped here, and then following which it can be divided, dissected from all surrounding structures, and can be excised. So this is a specimen of bilateral adrenalectomy, where we can see both the adrenals are bulky with multiple small nodules in them. So the treatment for peanut depends on multiple factors like their functional status, their location, their number, their distance from the pancreatic duct, and the options that we have are active surveillance. And in cases where there is some distance from the duct from the tumor, then we can do an enucleation like we had done in this case. For those where the duct involvement is present or they are very near to the duct, then a pancreatic resection like Whipple's procedure was done in this case where the pancreatic head mass was present. And in distal pancreatic lesion, a distal pancreatectomy with splenectomy can be performed. These are some of the relatively newer procedures which also can be performed. And for medullary thyroid carcinoma, the minimum surgery performed should be a total thyroidectomy with central compartment nodal dissection. And the lateral lymph node dissection is performed based on presence of metastasis on the imaging, or a prediction of metastasis based on the baseline calcitonin values. So these are all the lymph node levels that are to be dissected from level 2 to level 5. This is a surgical video of this is a surgical video of a left side selective lymph node dissection in a case of MEN2 patient where a total thyroidectomy has been done, the scar of which we can see here. And after making incision and after raising subplatysmal flaps, we can see that the sternocleidomastoid muscle is being dissected here. And after that, we can start the lymph nodal harvest from level 2 to level 4 by retracting the sternocleidomastoid muscle laterally. We can also see use of intraoperative nerve monitoring to identify and preserve all the important nerves that are present in the neck. And here we can see that the sternocleidomastoid muscle eventually is retracted anteriorly for level 5 node dissection. This is how the specimen looks after left side selective lymph node dissection from level 2 to level 5. Now I would like to welcome Dr. Divya for discussion of histopathology.
Thank you. I'll be discussing the histopathology of men-related tumors. So, coming to MEN1, it's a multi-system disorder which involves parathyroid, pituitary, and pancreas. So, out of which the most common is the parathyroid. And most MEN1 patients often manifest as multiglandular parathyroid disease. As we can see here, all the 4 parathyroid glands are involved. So next most common is the pituitary, in which the most common among the pituitary adenomas are the prolactinomas. And this is a representative image of a prolactinoma, which shows characteristic immunoexpression for PIT1 and prolactin. MEN1 patients present with pancreatic neuroendocrine tumors. The neuroendocrine tumors, the characteristic hallmark of the pancreatic neuroendocrine tumors, they can be multifocal, like more than 5 mm, or unifocal tumors in a background of microadenomas, that is ranging from around 0.5 to 5 mm. So this is a representative image of a patient who presented with a large tumor in the pancreatic head and uncinate process. And this showed immunopositivity for synaptophysin, chromogranin, and INSM1, which are the neuroendocrine markers. And they showed characteristic nuclear, paranuclear dot-like positivity for insulin, while they were negative for glucagon and somatostatin. So this is a case of insulinoma. The same patient presented with a tumor in the tail of the pancreas. This is a non-functional tumor. This showed immunonegativity for insulin, while they were positive for neuroendocrine marker like synaptophysin. Like pancreatic neuroendocrine tumors, this MEN1 patient, they can also be associated with neuroendocrine tumors in other organs like lung, thymus, and duodenum. So this is one such patient who presented with a duodenal neuroendocrine tumor, which had gastrin secreting cells, as is shown in the IHC. And the adjacent glands also showed neuroendocrine cell hyperplasia. In adrenal, MEN1 patients usually manifest as adrenal cortical nodular disease. As we can see here, there are multiple vague nodules which were immunopositive for calretinin, while they were negative for chromogranin. So other MEN1 related tumors, other MEN1 related skin tumors are collagenoma and angiofibroma. This collagenoma is a hypocellular tumor with abundant collagenous stroma and minimal vasculature. And angiofibroma, as we can see here, there are multiple ectatic vessels in an abundant collagenous stroma. So these are the other skin tumors which are MEN1 associated. So coming to MEN2, this is a gross image of a MEN2B patient. As we can see here, this is involved in both the lobes, right and left lobes, along with it's multifocal. It's a multifocal and bilateral MEN2B associated gross thyroidectomy specimen. This is a histopathological image of a medullary thyroid carcinoma in a MEN2B patient. This can show varied morphology like round to plasmacytoid, can be arranged in nest, and this is immunopositive for calcitonin. This is a precursor C-cell hyperplasia which is associated with MTC. And in MEN2B, the patients can also present with pheochromocytoma with adenomedullary hyperplasia. This is the adenal medulla which is extending to the tail and ala. The same histopathological image of the pheochromocytoma where the tumor cells are arranged in nest and cell balance pattern. And as we can see here, there is a reversal of the corticomedullary ratio. The medulla is involving almost the entire thickness of the adrenal. And as we know, MEN2B is very aggressive. So we had a patient who presented with medullary thyroid carcinoma metastasis to the adrenal, and this showed immunopositivity for calcitonin. So, MEN5 syndrome, which are the MAX-related tumors, other than the histopathology which we have already discussed, this patient can also present with ganglioneuroma and neuroblastoma. This is a histopathological image of neuroblastoma. That's a small round blue cell tumor with scant cytoplasm and inconspicuous nucleoli. Thank you. I'd like to call Dr. Halim for genetics.
Good afternoon. I'll be discussing about the genetic testing approaches is MEN2. MEN2 occurs due to disease-causing variants in red proto-oncogene. It's a proto-oncogene, and the pathomechanism is gain of function variants. So most of the variants are missense in nature. We can either go with the targeted testing for specific red variants. For example, if we have a clinical suspicion of MEN2B, we can directly go with the single sequencing of exon 16 for the targeted M918T variant. Otherwise, if we have a clinical suspicion of MEN2A, we can directly go with the selective exon sequencing of exon 10, 11, or 13 to 16 through Sanger sequencing for MEN2A uh, disease. Or if the targeted testing is negative, we can directly go with the single gene sequencing of entire red proto-oncogene that can detect missense, indels, and splice site variants. But since red proto-oncogene has approximately 20 exons, we have to do the sequencing through next generation sequencing based technique, either by a multi-gene panel testing or whole exome sequencing. ATA and NCCN guidelines say we should offer at least hotspot region testing for every MTC patient. And the hotspot region for MEN2A and MEN2B include exon 8, 9, 11, 13, 14, 15, and 16 in red proto-oncogene. The selective exon testing for exon 8, 10, 11, and 16 through Sanger sequencing are available at AIIMS and Division of Genetics, Department of Pediatrics. That can be the first year of testing that we should offer at least to our MEN2A and MEN2B patients. That cost around 2,100 rupees. The germline testing approaches is MEN1 and MEN4 are little different. These are tumor suppressor genes, and the pathomechanism is loss of function variants. So the most variants are missense, nonsense, frame shift, deletion. And since MEN1 and MEN4 do not have a good genotype-phenotype correlation, we should be doing the sequencing of entire genes. That again we can do with the multi-gene panel testing or the whole exome sequencing approach. If we are doing multi-gene panel testing, we should keep in mind that all the differential diagnosis gene for MEN1 and MEN4 should be covered in the multi-gene panel testing. If all these testing comes out to be negative, and very strong suspicion of MEN1, we should be offering our patients multiplex ligation dependent probe amplification, that is the MLDA for long deletion duplication for MEN1 suspicion. Genetic testing is just a small part of genetic counseling. That's a process of helping people understand, adapt to the medical, psychological, and familial implication of genetic contribution to disease. So we should offer genetic counseling that include pre-test counseling that help patients with informed decision regarding testing, different result scenarios, and potential implications. While the post-test counseling include the result disclosure, interpretation, and personalized context. It's a huge process starting with the family medical history taking, risk involvement, education, pre-test counseling, test selection, informed consent, interpretation, management, surveillance, cascade testing, and follow-up and support. Since we can make a clinical diagnosis of MEN1, MEN2A, MEN2B, MEN4, but genetic testing is of prime importance, and the cascade testing in at-risk family member who are asymptomatic as of now should be offered. That helps them with informed decision for prevention, early detection, and risk reduction of the associated clinical manifestation. And we can offer them surveillance or risk reduction options for the associated tumors and phenotype. Thank you.
Good evening. I'll be talking about our experience with these MEN syndromes for the past 3 to 4 years. So from 2021, after recovering from the post-COVID tardiness, we've seen about 24 patients of all the MEN syndromes combined, out of which majority have been of MEN2A, that is 11, closely followed by MEN1 with 10 patients, and of MEN2B being 3 patients. And that we have traced 10 back to 5 families, 3 of being MEN1 and 2 of being MEN2. And out of all these patients, we have genetic testing for about 30 to 40% of the patients because of the huge cost barricade that we have. In coming to MEN1 syndrome, total cases are 10 with the mean age of about 35 years, and the presenting illness was 5 with each PHPT and PNET. However, on evaluation, we found that hyperparathyroidism was present in all of the patients, with 70% patients having the pancreatic neuroendocrine tumor, and only 20% had the pituitary pathology. In MEN2 syndrome, MEN2A syndrome to be specific, the mean age was a little later, that is 40 years, with presenting illness being pheochromocytoma in 8 patients and MTC in the 3 patients. However, on further evaluation, MTC was seen to be present in almost all of the patients, and pheo was seen in about 70% of the patients. Then in MEN2B, which is probably the easiest to diagnose clinically because you see the patient and you diagnose. So we had 3 patients with the mean age of youngest 20 years, and 2 of them presented with pheochromocytoma, 1 presented with MTC. And on evaluation, all of them had MTC and 2 patients had pheochromocytoma. So in about 24 patients, we have performed about 45 surgical procedures, including all of these, majority being bilateral adrenalectomy, bilateral neck exploration, focused parathyroidectomy, total thyroidectomy plus central compartment lymph node dissection, lateral neck dissection. And for pancreas, we either do Whipple's procedure or enucleation or partial pancreatic resection, which has been equal in both. And the outcomes is that we have seen about 3 recurrences of primary hyperparathyroidism, 2 out of which were in focused. 1 was in bilateral neck exploration. There was 1 patient with persistent and recurrence of MTC, which eventually succumbed to it, case of MEN2B syndrome. He had metastatic MTC, and there is no recurrence of pheochromocytoma till now. And 1 patient was lost. So with that summary, I would like to invite Professor Sunil Chumber to deliver the concluding remarks.
So we saw that multiple organs are involved. That implies multiple departments should be involved for the diagnosis, for optimization, for intraoperative support, and the treatment part. So in most of the conditions, surgery is the mainstay, but we need support from chemotherapy in some conditions, and as well as our colleagues in nuclear medicine who offer PRRT or MIBG treatment. And this is not a common condition. The incidence around 1 in 30 to 35,000. So we need to detect all cases so that we can offer treatment early in the course of disease, and we can prevent mortality, because some of the conditions like pancreatic endocrine carcinomas, metastatic medullary carcinomas, then thymic carcinoids, and untreated POs. So they are almost fatal. So the key is multidisciplinary team approach, and follow-up is again very important, because as it is an inherited condition, we tend to get more patients in the same family. So we need to educate them about this inherited condition and get the entire family screened and treated. With this, I conclude the CGR, and I would like to request Professor Bal sir to share his vast experience. That was the last 3.5 years. Yeah, 2100. So outside it's 9,000. Here it is 20.
In fact, my first patient was in 2006. SDA was very that person. But while this died, that was in US. They rate it as well. Mostly related further up, we were submitting another patient when I asked him but once you see so then you may some
Thank you, sir. May I now request Professor Khadwal, sir, to share his experience of MEN syndrome.
and we do not have any nucleation movement nucleation. Most of these patients initially they present primary hypertherapy of MEN. So previously we were not suspecting and treating them and sending them to surgery and then preventing them. But subsequent follow-up we found out that many of these patients are not really and with the availability of genetic diagnosis, we do family screening and those who are genetic mutation positive, we keep them on strict follow-up. That way we are getting more and more patients, and now we have a large family of 25 members who are affected with their mutation positive. Many of them have been operated and few patients are still in waiting. Diagnosis is not that difficult with Rakesh has discussed all the tests available, this tests are available in our department, so we can easily diagnose this patient. Although mutational studies are not available right now with our department, somehow we get it done from the ground. We get it done from the outside this, and those who are positive are regularly screened every year they is screened down. Treatment wise, we have already.
Thank you, sir. Now I'd like to request Professor Chumbasar for concluding remarks.
Sir, I have a small question.
Yeah, you come here.
That's not multiple organ involvement. Each organ involvement has to be in what problem?
It is the medullary carcinoma. Most of the patients. Our patients, in fact, present having global disease. It's always very difficult and they have invariably a very high load of stuff. So you remove one set of lymph nodes, another set will arise further up. So you go and operate them again, they have metastatic disease, they will be present. I think Piyush himself has 2-3 such. So that is why it is imperative that diagnose them as early as possible and remove the emphasis of most modern treatment lies on. It's an old theme we have had since 1990 that we created. then come out with it unscreening the economy. So, pretty time, probably you would like to people starting our own city. But we have many patients who are sent for the diagnosis of PO with the legal diagnosis. So we have reversal.
So in syndromic MTC, actually the stage 4 survival is less than 25% in 10 years. Early stages are curable. So second is fear, untreated, we lose the patient. Third is pancreatic neuroendocrine carcinomas, grade 3 tumors. They are again fatal. So we can.
Still they are better than the cardiovascular cancer.
Yes.
Yeah, you go ahead.
Thank you, and thank you for all the support from Department of Endocrinology, Department of Medicine, Department of Pediatrics, Radio Diagnosis, Nuclear Medicine, Pathology, and Anesthesia, and at times dermatology, because some skin lesions are also diagnosed as a part of it. Thank you.